Okay, so a very good morning, all of my dearest viewers. How are you? कैसे बताएं कमेंट में और कहाँ से बताएगा. Okay, so it's fine. In today class, I am going to discuss the management of dengue fevers. In the previous lecture, I already told to you about the classification of dengue hemorrhagic fevers. So we can classify the dengue hemorrhagic fevers into the three categories on the basis of symptoms, and this categories is very essential in case of the management, because there are different management in different categories. So what are our approach when any dengue patients come to our clinics? So our first approach is we definitely go for the CBC count, total blood counts. So what would you expect in case of CBC count? So our first approach is we are going to check the WBC counts. So normally what's happen when any patient having the infection? So during the infection, is WBC count is elevated. Na you generally having a what normal WBC count 4,000 to the 11,000. So when any patient having the infection, so during the infection, this WBC count is elevated. Means the value is greater than 11,000. But in dengue virus infection, here the things are some complicated, or you can say that it is contradict the normal things that we. So what happened in case of dengue fevers? In case of dengue fever, here the WBC count is less than 4,000. In normal infection, WBC count is elevated, but in case of the dengue fevers, here the WBC counts get reduced, and whenever the WBC count is get reduced, we call it leukopenia. What we call it? Leukopenia. So leukopenia is one of the laboratory findings or investigation that you find in case of the dengue fevers. Is there are some other condition in which during infection the WBC count get reduced? Obviously, in case of JE, and in this condition also the WBC count is less than 4 condition. So in today lecture we are going to focus in dengue fever. So what are the first laboratory findings after seeing the CBC report? We observed that the patient WBC count is less than 4,000. Other things, patient having a thrombocytopenia. Patient having a thrombocytopenia. Sir, what is the meaning of this thrombocytopenia? Thrombocytopenia means platelets counts. Platelets count is less than 1.5 lakhs. So on the basis of this CBC count, there are two findings. We have to focus on two findings. One is that his WBC count. His WBC count is less than 4,000, and patient may having a thrombocytopenia. I mean his platelets count is less than 1.5 lakhs. Some other findings we have also focused on some other findings. What are the some other findings? One of the important finding is the hematocrits levels. Hematocrits levels. So now on the basis of this hematocrits level, we classify the dengue fever into the two categories. If the hematocrits levels is elevated 5 to 10%, if hematocrits level is elevated 5 to 10%, in that condition we consider it is a classical dengue fever. Classical dengue fevers. While if the hematocrits level is greater than 20%, if hematocrits level is elevated in a range of 5 to 10%, in that condition we kept patient as a classical dengue fever. While if hematocrits level is elevated more than 20%, in that condition we kept patient as a dengue hemorrhagic fevers. So greater than 20% dengue hemorrhagic fever. Okay. these are the common findings that you find whenever a patient comes to your clinics or your OPD or your hospitals, whatever, wherever, not whatever. Okay, it's fine. So after this laboratory findings, generally the dengue patients come to your hospital or your clinics in the febrile stages. The problem is in the febrile stage is in both classical dengue fevers and the dengue hemorrhagic fevers, they showing same symptoms in the febrile stages. So how we differentiate this dengue fever from they differentiate this classical dengue fever from dengue hemorrhagic fever. In febrile stage, we can differentiate dengue fever, classical dengue fever from dengue hemorrhagic fever. We wait for after 2 to 3 days when the febrile teacher when the febrile phase will be gone after 2 to 3 days or maximum 5 days. Now when febrile phase will be gone, in that after that we can differentiate a patient having a dengue hemorrhagic fevers or they having a classical dengue fevers. Because if a patient having a classical dengue fever, in that condition after the febrile states, the patient will enter into the recovery phases. But if a patient having a dengue hemorrhagic fevers, in that condition after the febrile phases, there is worsening in condition. I mean, patients are enter into the critical stages. So how we differentiate a patient is enter into the critical stage or the recovery phases? Definitely on the basis of this hematocrits levels. So when we check the hematocrits level in afebrile stages, when we check the hematocrits level in afebrile stages, and if you observe his hematocrits level is fall down or it is lies in normal range, then we conclude that patient is enter into the recovery phases. But if the hematocrits level are still persistent elevated, I mean its hematocrits level are greater than 20%, then we suspect a patient enter into the critical phases or now the patient having dengue hemorrhagic fevers. Also along with this increase the hematocrits level, there is a significant plasma leakage. There is a significant plasma leakage. So if a patient having a significant plasma leakage, that leads to the ascites and pleural effusions. So in further investigation, if we go for the ultrasounds and the chest X-ray, we observe a patient having a pleural effusions or the ascites. So these things we have to do after the febrile stage. We can't do these things in the febrile stages because in febrile stages there is no significant plasma leakage. So your test reports will be negative, sir. So what I am telling to you, we go for the chest X-ray and the ultrasound only in after the febrile stages. So if in afebrile stages we observe patient hematocrits level is more than 20%, and by ultrasound and the chest X-ray having evidence of the pleural effusions and the ascites, it is tells that the patient having a dengue hemorrhagic fever. So on the basis of this investigation, we try to find a patient having a dengue hemorrhagic fevers or they having a classical dengue fevers. So now we go for the treatment parts, how we manage such patients. So we start patient with a simple classical dengue fevers. Okay, first we have to erase my board. Then I am telling to you about the what classical dengue fevers. Okay, so we start the management with the classical dengue fevers. Classical dengue. We start the management with the classical dengue fevers. Let's see. But what are the findings in classical dengue fever? I already told to you. So there is no any requirement for further writings those things. Okay, so in classical dengue fevers, obviously the first phase is the patient having a febrile stages. So febrile stages, what we do? Simple. For the fever, we generally give paracetamol tablets. In febrile stages, we given 500 milligram paracetamol tablets 3 to 4 times in a day, with an interval of 5 to 6 hours. So in febrile stage, we give 3 to 4 tablets paracetamol tablet with an interval of 3 to 4, not 3 to 5 to 6 hours. So what is the maximum? How many maximum paracetamol tablet we have to give patients? We maximally gives 8 tablets. We maximum give 8 tablets because 8 tablets now after 4 grams having chance of paracetamol toxicity, and one tablet contains 500 milligram. So if one tablets contain 500 milligrams, two tablets contain how many gram? 1 gram now. So obviously 8 tablets contain 400 gram. So we maximally gives 8 tablets in a patient. If giving 3 to 4 times in a day paracetamol, here what is the quantity you give? If we take higher limit, that is 4 tablets, that means you gives 2 gram tablets. So if even giving a 2 gram tablets of the paracetamol, still the patient is reappear with the fevers, then we add 1 or 2 more tablets, but we maximally gives 8 tablets. We not go beyond the 8 tablets, because if you go beyond the 8 tablets, having higher chances of paracetamol toxicity. So we maximally gives 8 tablets paracetamol in a day. So this is the role of management in case of the febrile stages. Along with we also add some multivitamins tablets like Ginkgo, but this Ginkgo is not main role of treatments. They are basically having a supplements role, because if a patient having significant plasma leakage, so there is no metabolic disturbance, that we add Ginkgo tablets. And if a patient having a complaints of gastritis, in that condition we also go for the omeprazole or the pantoprazole. So these both tablets are the supplementary. They are not a main role in treatment of this dengue fevers. So after discussing these febrile phases, and since we are going to discuss, since this is the classical dengue fevers, so there is no any need of further treatments. Even after 2 to 3 days, the patients enter into the recovery phases, and then we go for then we discharge the patients. But if a patient, if after febrile stages, if febrile stages will come, and there is worsening in condition, I mean hematocrits level is elevated, having evidence of the significant plasma leakage. So this is the condition of the dengue hemorrhagic fevers. So now we are going to discuss how we manage this dengue hemorrhagic fever. Okay, how we manage the dengue hemorrhagic fevers. Management of dengue hemorrhagic fever. Why are you repeating the same word multiple times? Dengue hemorrhagic fevers. Okay, so let's see. Dengue hemorrhagic fever, we further classified this dengue hemorrhagic fevers into the 3 categories. Okay, what are the 3 categories? First, dengue hemorrhagic fever. First, dengue hemorrhagic fevers without shock. First, dengue hemorrhagic fever without shock. Another is dengue hemorrhagic fevers with compensated shock. And the third is the dengue hemorrhagic fever with decompensated shock. Okay, so after discussing the classical dengue fever, we are going to discuss dengue hemorrhagic fever, which is a more severe condition than this classical dengue fevers. So in dengue hemorrhagic fever, we basically classified into the 3 categories. One is without shock, another is shock but it is compensated, and another the third is the decompensated shock. So first we are going to discuss this dengue hemorrhagic fevers without shock. Dengue hemorrhagic fever without shock. Okay. So how we find out a patient having a dengue hemorrhagic fever with shock? One of the clinical finding is a patient having a complaint of gum bleedings, or what epistaxis. Epistaxis means nose bleedings. Let's say this gum bleeding and nose bleeding, this is not classical for the dengue hemorrhagic fever. It may be seen in case of the classical dengue fever, but in most of the case it is seen in case of the dengue hemorrhagic fever. That's why I discuss these things here. So these are the clinical findings. Patient having complaint of gum bleedings and the epistaxis. Other things, if patient having a without shock. So if a patient having a without shock, that means his vitals are normals. His vitals are normal. I mean his blood pressure are normal. Blood pressures are normals, and what? Blood pressures are normal, and also heart rates are normal. Pulse pressure normal. So all these vitals are normal. So if all our vitals are normal, so what are the abnormals? Abnormally, they having a hematocrits levels. They having a hematocrits level rise 5 to 10%. Hematocrits level rise 5 to 10%, and also they having a thrombocytopenia, any platelets counts. They are less than 1.5 lakhs, but more than 1 lakhs. So his first finding is that his hematocrits level is elevated 5 to 10%, and the another finding is platelets level will definitely reduce, but it is not reduce beyond the 1 lakh. So it is like something between 1 lakh to 1.5 lakhs. So basically on the basis of these two findings, we consider patient that they are having a dengue hemorrhagic fever without shock. So what are the management in this condition? We start with IV infusions, and the name of IV fluids is the ringer lactate. Ringer lactate. Okay. One more point we have to discuss, and it is very important to discuss these points, because let's see, whenever we are going to administrate this ringer lactates IV fluids, the first things we have to check the patient having a no hyperkalemia. What is the contraindication? The patient having a no hyperkalemia, because this ringer lactates, they itself having a potassium. So if a patient having already high potassium level, and we are going to infuse such fluid who also having a potassium level, so they worsening the condition. That's why we avoid the ringer lactate in case of the hyperkalemia. So which fluid we prefer? In that condition we go for the normal saline. That condition go for the normal salines. When we go for the normal salines, when a patient having a hyperkalemia, normally the preferred fluids is this ringer lactates. But if a patient having a hyperkalemia, in that condition we go for this normal saline. So this point is very important, because if a patient having a hyperkalemia and we are going to infuse this ringer lactates, then definitely you worsen the condition. Okay, so what are the infusion rates? We start the infusion with a 6 ml per kg per hours. So we admit the patient and start the infusion with 6 ml per kg per hour for 2 hours. Now after 2 hours we reassess the condition. If there is the improvements, then we reduce its value, and if there is no improvements, then we continue this infusion of rate 6 ml per kg per hour, unless and until the patient not showing any improvements. So let's suppose patient showing improvements after the 2 hours, his hematocrits level is falls down, then we reduce this infusion value. Initially we start with the 6 ml per kg per hour. Now it will change into 3 ml per kg per hours. After 3 ml per kg per hour, we further reduce this value 1.5 hours, and then you observe that a patient are able to eat and drinks. Then we go for the oral fluids. Oral fluids. Okay. So these are the management of the dengue hemorrhagic fever without shocks. Now we are going to discuss the management of dengue hemorrhagic fever. First we discuss compensated shocks, then we are going to discuss decompensated shock. Okay, so we start the discussion with dengue hemorrhagic fever with compensated shock. Okay. Dengue hemorrhagic fevers with compensated shock. Dengue hemorrhagic fever with compensated shocks. Okay. So first contraindication is must for all three conditions. We not gives ringer lactate if a patient having a hyperkalemia. So we suppose that a patient having a not a hyperkalemia, they are the normal patients. So what happens if a patient having a compensated shock? So first, how we decide a patient having a compensated shock? What are the criteria for taking decision patient is compensated shocks or the decompensated shock? The first criteria is obviously the hematocrits levels. Its hematocrits level is rise by more than 20%, and the platelets counts they are less than 1 lakh. In without shock condition, his hematocrits level is rise by 5 to 10%, and the platelets count is reduced by 1.5 lakhs, but it is not below the 1 lakhs. But here the both parameter will be increases. Its hematocrits level will elevated more than 20%, and platelets count is below 1 lakhs. So these are the two important criteria. Now along with they also having a normal systolic blood pressure, that is it is lies between 90 to 120 mmHg. But the abnormality is they having a elevated diastolic BP. Diastolic BP is elevated. Okay, it's fine. Why? Now question is right, why this diastolic BP is elevated? Let's see. In this condition there is a significant plasma leakage. So whenever there is the significant plasma leakage, obviously the circulatory blood volumes capacity get reduces. So if blood volumes capacity get reduces, in that condition what are the importance of our or what are the first priority of our body systems? They vasoconstricts the peripheral blood vessels and try to supply more blood to our vital organ now, because our vital organs are more preferable for our system to so they maintain a proper tissue perfusion. So that's why they vasoconstrict the peripheral blood vessels. But the problem is that whenever there is the vasoconstriction in the peripheral blood vessels, as a result, what happens? They increase the peripheral resistance. So if peripheral resistance is increases, this peripheral resistance increases this diastolic blood pressure. So this diastolic pressure is increases due to the peripheral vasoconstriction, followed by increasement of peripheral resistance. Okay, so after discussing these diastolic blood pressure elevators, what are the other things? Patient felt cold and clammy. Patient feels cold and clammy. This is also due to the peripheral vasoconstriction. Whenever patient having a peripheral vasoconstriction, definitely the area where the no proper blood supplies. So if there is no warm blood reach to that region, definitely the patient feels warm, and this clammy is because they stimulates the parasympathetic nervous system, and this parasympathetic nervous system stimulates Spitz glands. So due to this stimulation of parasympathetic Spitz glands and the peripheral vasoconstriction, patient feels cold extremities and clammy. Cold extremities and clammy. Okay, what are the other finding? Or other finding is that patient having a tachycardia. Due to this tachycardia, no, this systolic blood pressure is maintained, because if patient having no tachycardia, no, even this systolic blood pressure get fall down. So patient having tachycardia and patient having a reduced capillary fillings. Patient having a reduced capillary fillings. So these are the findings that you found in case of the dengue hemorrhagic fever with decompensated, not decompensated, it is decompensated. So okay, after discussing this criteria for decide a patient having a decompensated and the compensated shocks, now we are going to discuss the management of this decompensated shock. Okay, that's fine. What we start? We start with ringer lactates with a contraindication that patient may not having any hyperkalemia stages. So ringer lactate, what are the infusion rate? Ringer lactate with the infusion rates of 10 to 20 ml per kg per hour, and we give this fluid for 1 hour. Okay, why we write this two value? This two value is right because this is the maximum limit. We can't cross the maximum limits. We start the fluid infusion with 10 ml, and no, after reassess the condition, we can increase the IV infusion, but not we go beyond the 20 ml. So after 1 hour, what we do, we go for a reassessment, and in reassessment there are two possible things: either patient showing improvements or there is no any improvements. So there are two conditions: patient showing improvements. If a patient showing improvements, we reduce the IV infusion. Now we start with the 10 ml per kg per hour. Now we reduce this to 6 ml per kg per hour, and we infuse it for 2 hours. After 2 hours, we again reassess the condition. If improvements are showing, then we reduce this value for 3 ml. After 3 ml, then we reduce this value of 5 ml. And now if patients are able to drink or take food, then we shift for the oral fluids. Okay, so these are the procedures through which we go if a patient showing improvements. So what happens if a patient showing no any improvements? Now another criteria is the patient showing no any improvements. So in no improvements, they also having got two possibility. First things is that there are two possibilities. First things is there is no change in hematocrits levels. Its hematocrits levels are still elevated. There is no change in hematocrits level. Its hematocrits levels are still elevated. So if there is no change in the hematocrits level, now we continue this infusion of 10 ml to 20 ml per kg. We infuse this 10 ml 20 kg till the patient showing any improvements. That's why we write this range 10 to 20 ml. We start with 10 ml, and if a patient showing no any improvements, we increase this value for, let's suppose, 15 ml, then 70 ml, but we maximum go for 20 ml. We no go for the 20 ml. So in this criteria, we can increase the amounts of IV fluids, and if a patient showing improvements, then start decreasing its value and go for the oral fluids. The another condition is that here the hematocrits level is fall downs. Here hematocrits level is fall downs. But the problem is that along with the fall down of this hematocrits levels, the patient hemoglobin's level is also fall downs. Two things are happening in this condition. Patient there is fall downs of the hematocrits level, but the problem is that along with falling down of this hematocrits level, his hemoglobin's level is also start falling down. So why this hemoglobin is also start falling down along with hematocrits levels? This is because it is indication of internal bleeding. It is indication of the internal bleedings. And if a patient having an internal bleeding, they having a history of hematemesis and melena. So this hematemesis and melena confirm that a patient having a internal bleeding. So if patient showing internal bleeding, in that condition what our approaches, in that condition we gives patient 10 ml per kg whole bloods, 10 ml per kg whole bloods, या 5 ml per kg RBC packs. So this we are going for these two things if we suspect any internal bleedings. After that again we go for the ringer lactate fluids, and if improvement is showing we reduces its value, and finally we shift to the oral fluids. So these are the one more things we are like to discuss. What are the things? Let's see. This is the condition of shock now. In shock condition, there is reduced tissue perfusions. Even in spite of patient having a normal systolic BP, they are having chance that the tissue not receives a proper oxygen. So if a tissue not receives a proper oxygen, so what happens? They shift the respiration process from aerobics to anaerobics condition. So if cell undergoes anaerobic respiration, in that condition it leads to the formation of what's lactic acids. In that condition it leads to the formation of the lactic acids. So if in blood circulation there is increased H plus levels, if in blood circulation there is the increased H plus levels, what this H plus increased level will do? This H plus they interfere the troponin sites of the myosin, which is responsible for the contractility. So this H plus ions they disturb the contraction of the myocardial tissue. So if they basically they reduce the contraction of a myocardial tissue. So here is a condition where there is the requirement of more strength full contraction, and this lactic acid decrease the strength of contraction. So they worsening the condition. So if by taking blood reports we suspect a patient having a acidosis condition, then we go for a inotropes. Then we go for the inotropes, and the name of inotropes is the dobutamine, epinephrine. Whatever we choose according to your choice, both are equally effective. So if we suspect acidosis, then along with IV fluid we also go for this inotrope. These inotropes maintain the strength of contractions, so they not fall. So they ensure that there is no any sudden fall downs of blood pressure, and patient not undergoes in hypotension condition. So after discussion these all things about the decompensated shocks, now we are going to discuss what decompensated state shock. Decompensated stage of management in case of dengue fever. Okay, dengue hemorrhagic fever with decompensated shock. Decompensated dengue hemorrhagic fever with the decompensated shocks. Okay. So first, what are the criteria of the decompensation? Definitely, first we go for the hematocrates levels. Hematocrates levels are more than 2%. Platelets count is obviously less than 1 lakh. And the major importance criteria is the patient systolic blood pressure. Patient systolic blood pressure is less than 90 mmHg. Less than 90 mmHg. That means patient enter into the hypotension stage. Patient enter into the hypotension stages. Let's see, if a patient blood pressure is ranged between the 70 to 90 mmHg, in that condition the BP are recordable. In that condition BP are recordable. But if a patient whose blood pressure is less than 70 mmHg, blood pressure less than 70 mmHg, in that condition the BP are unrecordable. BP are unrecordable. So this is the more severe condition. In that condition, we some hospital they go for the artificial circulatory supports, and if they having no artificial circulatory support, then they go for inotropes. These are things I will discuss. Wait for some minutes. Okay, so what happens? These are some other criteria. Definitely they so having cold extremities plus clammy nature, and delay capillary fillings. Okay, so after these things, now we are going to discuss the management parts, how we manage such patients. Okay, what we do in case of the compensated shock? In compensated shock, we start with the ringer lactate. No, so in decompensated stage, we also start with the ringer lactates. But a difference is that in compensated shock, we start ringer lactates of an infusion of 10 to 20 ml per kg per hour. Here we start the infusion of 10 to 20 ml per kg per hour, but duration is for 50 to 20 minutes, 50 to 30 minutes. That means no, here we reassess the condition every 50 minutes, and after when we reassess the condition, definitely there are the two things is possible. One thing is what patient showing the improvements, patient not showing improvements. If not showing improvements, there are two conditions possible. Its hematocrits level are still elevated, and if hematocrits levels are still elevated, now we maintain this IV transfusion. Maintain IV transfusion unless and until now patient hematocrits level is fall down. The another thing is hematocrits level is fall down, but along with the hemoglobin level is also fall down. So in that condition, we go for the blood transfusion. If we are going for the blood transfusion of the whole blood, then it is 10 ml per kg, and RBC then 5 ml per kg. After that, we also check the acidosis condition. After that, we are also checking the acidosis condition. If having acidosis, then we go for the inotropes with IV fluids. So basically, the management is almost same in case of this compensated and the decompensated condition. Only difference is that in case of the decompensated stage, there is a rapid infusion. In less time, we infuse lots of fluids. So when we in less time we infuse lots of fluid, the condition is called bolus infusion. So here is what we are going for, the bolus infusion. So these are all the management parts of the dengue hemorrhagic fevers. I hope you understand the lectures, and in next lecture I am going to discuss about the malaria. So good night. See you in next video.